Hello, my name is Coda Atkins, and for my project week, I went to the ER four times, and I was and I researched about anything that I found interesting and about how to be a nurse. My whole project is about finding out if I really want to be a nurse, as the life can be difficult, and I want to make sure I am dedicated to this before I put time, energy, and money into going to nursing school if it's really not my passion. So I'm excited to tell you all about what I found out and what I have researched and about my ER experience. Hello. So before I could even go to the ER, there were a lot of things that I had to do. First, I had to get CPR certified with basic life support certification. I had to get HIPAA certified. I had to take both the COVID and flu vaccines, and I had to get tested for tuberculosis, and I had to buy scrubs. I also had to get a background check and I had to get a drug test to ensure that I am not doing any drugs and that I haven't done anything in the past that could make me a threat to the hospital and the patients in the hospital. These are all really important because you want someone who is caring and who is a good person to be your nurse and to care for you. And a lot of patients believe that all the nurses are like up against them, trying to hurt them, and a lot of patients can be very paranoid. So it's good to know that really nurses have background checks. They're not on drugs. They're not doing anything diabolical. They're just there to help you and to care for you. And even if that's not what you imagine it would look like, that's their primary goal, is to help you. Not to say that there are no bad nurses. There can be a lot of nurses that have done bad things and that really don't have the patient's minds the patient's hearts in their heart, and the patient and don't want to care for their patients. But that is usually found pretty quickly, and any negligence is found because nurses are monitored and videoed, and not videoed, but there are cameras in the hospitals, not in the patient's rooms, but around, to see if the nurses are talking about anything, if the nurses are trying to get any information on the patients, if the nurses are trying to get any drugs or medicine or needles from the hospital itself. There are cameras, there are locks, everything is protected, and it will be found out if there's negligence through with the nurses through these ways. I also I had got CPR certified before, but I had to get it again, and I thought that was really interesting. I learned a little bit more about rescue breaths and about the Heimlich maneuver and the best ways to do that, and I will show you all later in the video on how I learned and what I learned to do that. And then for HIPAA certification is very important because it's to ensure that the nurses are going to protect the patients, that anyone in the healthcare system, even if you're not a healthcare worker, if you work with a medical facility, you need to be HIPAA certified to ensure that the patient's data and their privacy is protected, and to ensure that there is no leakage. And if there is a leakage, then HIPAA will come in and be able to help and there's legal compliance when you are legally complied to work with HIPAA, and if you don't, then there will be repercussions for that legally. And if they're not HIPAA certified, there's likely not a way to get repercussions against someone who stole data. If they stole data and they leaked data on accident, then if they're not HIPAA certified, there's no way to legally charge them with through HIPAA. So it is to ensure that any wrongdoings are justified and legally, and that the patients are protected and their trust is protected. I also had to get the COVID and flu vaccines, which all vaccines are really important. They're not some microchip or tracker that the government is trying to put into you to track you. You already have a phone that is being monitored a lot by the government, but that's not what vaccines are. They're not some diabolical way to get into your head or anything, which, if it sounds crazy to you, then that's good. because it should sound crazy, but to a lot of people it doesn't. It sounds realistic, but it's not. You have to get, at least with flu and vaccine and COVID vaccines, you have to get that every year because there are new strands of COVID and the flu that are coming out, and that they're evolving and they're worsening. And when you work with people who are already, their systems are already weakened, then getting flu or the COVID can be detrimental to them. It can lead to their heart being weaken the immune systems, weaken the heart, and it's not as well protected, and there can be diseases and brain diseases that come if you get COVID or flu, and if you're already weakened already. Young people and people that aren't sick and healthy, if they get flu or COVID, it's not that detrimental. But if someone is already really weak, then it can be very, very bad. And this is a way to protect the patients and also to protect the nurses, just in case they get anything. And the same with tuberculosis. While it's not running rampaged here, if I had been exposed to it and I brought that into the hospital, then it could be detrimental to the patients and to the nurses. And honestly, they get tested every year with a PPD test to ensure that they weren't exposed to it, because nurses and healthcare workers work with all kinds of patients who have been all over the world, and you don't know if they've been exposed to tuberculosis, or if they have it, you don't know, and it could hurt. And it's to protect the nurses. They get tested every year to protect themselves, and the patients as well, but mainly themselves, because they are more at risk because they deal with so many patients from so many different places. And then a little bit about scrubs. I didn't realize how important they were, but the material that scrubs, I thought that they were just, what healthcare workers wore, and there was no reason behind it. Obviously, there is a reason. It's because the material that the scrubs are made out of are able to be washed in really high temperatures every single day without shrinking or damaging the material. This is to ensure that all pathogens are eliminated every single day after wearing them. If you wear regular clothes and you get bacteria or a virus it can be cross-contaminated if you can't kill it with the hot water. And you can't wash your clothes in hot water every single day. So that's why scrubs were made with the material that they're made with, to ensure that all pathogens are eliminated and that there's no cross-contamination between patients. So I thought that was really interesting. And I will go into how to perform CPR and the Heimlich maneuver next. Hello, and today, right now, I'm going to show you how to perform the CPR on both an adult, an infant, or a child. The differences that happens to have based on the size and the age of the adults and the infants and children, and also the differences between being by yourself or being with another responder, and what practices you need to perform if there's that. As you cannot perform CPR on a person if they're not in danger, this is because CPR, when you perform CPR, you will break a rib. That is a guarantee. Because with the strength that you are using to revive the person, you are going to break a rib. And so that is actually why there are Good Samaritan laws in place in case someone needs to perform CPR that is a regular person to perform CPR on someone else. That regular person is protected by Good Samaritan laws. But right now I'm going to show you I don't have a mannequin to show you with, so I will be using my little Spidey. He's going to be a good volunteer. So let's say he was an adult and I'm by myself and he passes out. So first you run up to them and you ask if they're okay. If they don't respond, then you check their pulse using the carotid pulse. And if there's no pulse, and you check their breathing using the breath, the chest, if there's no rising and you can't feel any breath coming out, then that means that they are not breathing and they have no pulse, and you need to first call for help, then get an AED, and while that is starting up, you immediately start CPR. So with an adult, the compression to breath ratio is 30-2 if you're by yourself. If you're with someone else, then it's 15-2, so 15 compressions and then 2 breaths, and then you switch off. And if you're by yourself, you keep doing it. You keep doing it until you can't anymore. And then the depth of the compressions with an adult needs to be 2 inches. And do not lean on the person. You need to be upright and holding yourself up and pressing down, but not leaning into them. Okay, you don't need support from them. You need to be doing the compressions, right? And to do compressions, you have your dominant hand down on the chest, on the sternum, which is in the middle of the center chest, and then your non-dominant hand is supporting it on top of it and holding that wrist, and then you will do 30 compressions, and they will look like this: 1, 2, 3, 4, 5, 6, and until you do 30. I'm not going to do 30 compressions right now. I'm not going to make you sit through that. So if it is a child, the difference is the depth. If it's someone between 12 and 18, then the depth of the compressions needs to be 1.5 inches to 2 inches. So just a little less depth is needed, just like that. And then if it is an infant, the difference is both the way you do compressions and the depth. The depth needs to only be 1 inch to 1.5 inches. And the way you perform CPR with an infant is either with you definitely do it with 2 fingers. It's either with the pointer and the middle finger like this, and into the sternum like this, and pressing down like that. But that can be very difficult. So a preferred way for me is to use your thumbs. So you align your thumbs with their nipple line, and you press in like that, and like this. And if you're with another person or responder, you use the thumb method, but you get on your side and you use one thumb, and then they'll use the other thumb to link up, and you will do the compressions at the same time. And then for the Heimlich maneuver, basically if it's with anyone, if they are shorter than you, then you need to kneel against them like this and do that. But if they are taller than you, then you line up with them, and I'll show you myself. Then you find their navel, which my navel is right here. You put your dominant hand in a fist against their navel, and wrap the dominant hand with your non-dominant hand, and then press up like this, up, up, up. And if the person you are performing the Heimlich maneuver on is pregnant or is a larger person and you can't wrap around their stomach, then you will do it to the chest. The same thing, but at the nipple line again. Same with the dominant hand is in a fist. The non-dominant hand is wrapped around it, and you will be going up. And then if it is a baby, this can look very violent, but it's not. It needs to be done. We're gonna say Spider-Man is the baby. You will put the baby on your arm like this, with its chin in between your arm, in between your fingers, and then you will, I'm gonna go to the side so you can see, you will pound 5 times against the back, like this. 1, 2, 3, 4, 5. Again, very violent, but necessary. And then you will switch them to the other arm and perform with the CPR with the pointer finger and the middle finger, and you will do that 5 times as well. 1, 2, 3, 4, 5. Flip them around. 1, 2, 3, 4, 5. And you will do that continuously. And every time you flip them over, only if you can see the obstruction, you will do a finger swipe. If you cannot see that obstruction, do not do a finger swipe. Do not blindly swipe your finger in their mouth, because that can push it farther down. If you don't know where it is, don't attempt it. If you can see it, attempt it. And still that can be dangerous. So be very careful with that. You do not want to push it further down their throat and into their trachea. You want it out. So don't just blindly sweep. And then for rescue breaths for an adult, it is 1 breath over 1 second, and you will do a breath every 5 to 6 seconds. So let's say it's Spidey, you will have, I don't have the breath pump, so I'm gonna put a picture of it right here. And basically you put your hand in a C like this, and you seal it against their nose and their mouth. So like this, against their chin. And then you do 1 breath, and you don't squeeze like that. You do very little. You just squeeze until you can see the breath rise. Just little squeeze, 1 breath. 1, 2, 3, 4, 5. 1 breath. And then you continue that. If they don't need CPR. But if they do need CPR, then you do 1 breath, and continue CPR immediately. And then if it's with a child or an infant, they need 1 breath over 1 second. So 1 breath should take 1 second. That's what that means, just to ensure that that's clear. And they need a breath every 2 to 3 seconds. So it'll be 1 breath, 1, 2, 1 breath. So quicker, because they need that, they need air into their lungs quicker than adults do. And yeah, that's what I learned from the CPR and the basic life support training, and I'm glad to show it to you, and thank you for listening to that. All right, so next I will be showing you how to find the carotid and the radial pulse. The carotid pulse is very easy to find. It is against the jawline right here. And basically, when finding a pulse, you always use your pointer and your middle finger. You never use your thumb, because your thumb has a pulse in it, and you will be monitoring your own pulse instead of the other person's pulse. So you will basically take those 2 fingers and you will feel against the jawline right here. Until you find it. Okay, got it. It can be a little different on other people, so you just gotta feel in that general area until you find it. And then for the radial pulse, I'll take off my watch. Sorry. It is between the, it's going to be between the radius bone that is going to be right here with the in line with the thumb, and the radial artery, which is right here. And basically it's going to be a little, it's going to be right here along this. It's just going to be a little dip. You'll be able to find the pulse in that little dip between the radius and the radial artery. Got it. That one was quicker. Usually it's not, but you do want to use some pressure, but you don't want to press against it like that, because that will basically cut off the pulse, not hurting their heart, but you won't be able to feel it because you're pressing up against it so hard. So you want to give some pressure, but not too much. And yeah, that's it for that. All right, so right now I'm going to talk to you about the first day at the Brattleboro Memorial Hospital, or BMH for short. I will be referring it to BMH now. So yeah, and I will be de-identifying all of the patients that I discuss in protocol to HIPAA. So I will not, I can talk about what I saw, but I cannot identify any patient. I can only say, refer to them as patient and their ages if I need to, but I cannot say any names or any social security numbers or anything that I learned that about the patient that could identify them. Because I was in the ER, there are so many patients that I saw. I am only going to talk about the ones that I learned from. Especially with BMH, there were only a few patients, but there are so many people that go to the Brattleboro Memorial Hospital every single day. There's no way to identify any patients based on the information that I give. So just as a warning, I am allowed to talk about what I learned and about the patients, but as long as I de-identify them. So I just wanted to clarify that. I'm not going against HIPAA in any way. So let's get into it. So I saw 4 patients in total. There were more, but I wasn't allowed to see them because a lot of them were there for suicidal intention and mental illness. And I will discuss at the end why that is so such a big deal and such going rampant. There's in hospitals everywhere in the ER, there are suicidal and mentally ill patients, and I will discuss a possibility to that. So for patient number 1, I will refer to them as patient 1, 2, 3, and 4. So for patient 1, I saw her. I saw her get an IV, and well, she had already had an IV. I saw her get her blood drawn, and to start, before she could even get her blood drawn, she needed a saline injection into the through the IV tube, and basically this cleans out the tube and any blood, and kind of helps bring that blood to the vein that has that the IV is in. It helps kind of regulate that blood with the saline solutions. And then I saw Michael, who I didn't follow Michael. I didn't say this first. I followed Martin, a technician who is an AEMT who is he was an EMT first, and now he's working to get his nursing license and to become more of a nurse. And to get more experience. So I followed him around. So I saw a lot of the technical stuff in the hospital, but I did follow Michael a little bit around. He actually used to work at the Putney school, which is really cool. 6 years ago, he stopped. So he was really welcoming and helped me a lot, especially that first day. So I saw him. He explained to me that when you draw out blood from a tube, and after you put in the saline solution, you always need to get a vial of waste, which is taking out some blood that still has the saline solution in it. So usually the nurses will put the waste in a smaller syringe and then draw up more with a bigger syringe, and that's how he differentiated the waste between the blood that needed to be tested. And then after that, he hooked up a needle and to the larger syringe that had the blood that needed to be tested, and that needle has I'll show a little picture right here. It has a tube thing, and when you put the vacutainer, which is the tubes that hold the blood, when you put it in, the vacutainer will suck up as much blood as it needs, and that's really good. And then and that's what I saw for that patient. She had an GIB lead, so she was pooping out blood. And when a patient poops out blood, it will look like just plain up blood. It won't look lighter and it won't look darker. It will look like straight up blood that is coming out of their body. Some people don't realize that before they see it. But that I didn't get to see it. She had already flushed it before, which sounds really gross. But it is good to know what it looks like when there's a GI bleed. The symptoms for that is pooping out blood, and it's good to know to be able to identify what that blood looks like when pooped out. But Michael explained that to me, and then next I saw Martin draw blood from a suicidal patient who I'll refer to as patient 2. He goes there a lot, but he was feeling better, and he wasn't being violent in any way. He has been violent before, so the nurses were nervous about me going around him, but he was totally chill and super nice, and he let Martin take up his blood. Martin used a butterfly needle this time, so there was no need for a saline solution. He just used a 21 gauge butterfly needle, which when referring to needles, the larger the number, the smaller the needle. So if there's an 18 gauge needle, that's a big one. That's a big needle. If it's a 25, typically patients use 21 to 25 needles because it's smaller and it hurts less, a lot less. You don't want to use an 18 gauge or anything lower than that unless you need to. So yeah, he used a 21 gauge needle, and he didn't need the saline solution, and everything. He got that. He used the vacuum to suck up that blood, and sent it to the labs. And for the next patient, patient 3, I saw an EKG for her. Sorry, I'm reading my notes as I talk about this. So she had a shortness of breath and pain in her back between her shoulders, and it would worsen when she laid down. And so when you get an EKG, it is monitoring the electrocardial cardio of the heart. Is monitoring what is going on with the heart and the beating. And it's very hard to interpret. Actually, at the Brattleboro Memorial Hospital, the BMH, their nurses are not allowed to interpret the EKGs, but Martin explained a little bit to me. Basically, when you're looking at an EKG, you're looking for abnormal, like increasing or abnormal elevations in any of the segments of the heart. There are, I believe, 10 segments of the heart. And you are just monitoring that. And yeah, there were a lot of mentally ill patients and addicts that come to BMH, and a possible reason, my father was a paramedic, and he explained to me that that back in the late 80s, early 90s, when AIDS and hepatitis was running rampant and no one knew how to combat that, a lot of the funding from mentally ill facilities got redirected to AIDS and to fight AIDS and hepatitis, and to do more research on that. They needed more funding, so they took from the mental facilities. I don't know if that's still an issue today, but it is likely that they never recovered. So there is no middle ground. There's if you are suicidal or have any intent of hurting anyone else due to a mental illness, you are sent straight to the ER. There's no and then after the ER, you're sent to a inpatient facility or an outpatient facility, depending on what is needed. But basically, any patient that is suicidal or mentally ill and having any feeling any kinds of ways, if they're feeling like they want to hurt someone else or hurt themselves, they get sent to the ER immediately. And that creates a lot of flow of patients into the ER, and that's everywhere, not just here. It's in Georgia, it's in every other state. I say Georgia specifically because my father worked in Georgia, and he saw a lot of suicidal and mentally ill patients, because there were only two, like near him where he worked, there were only 2 hospitals, and and like 10 counties. So a lot of people that were mentally ill and suicidal in those 10 counties could only go to 2 hospitals. So he saw a lot of flow and a lot of on the ambulances, a lot of suicidal and mentally ill patients. So I'm just speaking from his experience. And yeah, that was Brattleboro Memorial Hospital Day 1. Okay, so I forgot to explain how to start an IV. That's what I learned from patient number 4 from BMH Day 1. Basically, you use a tourniquet, which is a rubber band, and you wrap that around the upper arm, and doing that will stop the blood flow, blood from flowing out of the vein, and it will cause the vein to swell up. And when you feel the vein, I felt it a little bit, it feels like a little water balloon. That's the best way to describe it. It feels swollen, and like you can press it and it's bouncy a little bit. And then you clean that site, and then you will take a needle, and it will be a hollow needle, and you'll stick it in and pull out, making it hollow, like pull out the middle part of the needle, and plug in and press and stop the blood flow, and then plug in the tubing for the IV, and then you will inject another saline solution into the IV to clear up the blood and to make it come to the vein quickly. And then you will cut off that again with, on the tube of the IV, there is dial kind of thing. I will show a picture of an IV, and basically that little slider will stop the blood flow. And yeah, and then you will attach the tube and secure the IV and attach it to the outer side of the patient. It's best to do that because the reason is if there's an emergency and that patient needs to get a blood test immediately, or they need to get blood like through the IV, or they need a saline solution if they're extremely dehydrated, or they need some kind of drip medication, then it is easier for the nurses and the doctors to to get the IV to get that attached to the IV if it's on the outer side of the patient. If it's on the inner side, it'll hit the patient and it'll be harder to reach and get it. So it's just easier access for the nurses and the healthcare workers, and you usually immediately just attach it to the outer side. Unless the patient says something, then you can attach it to the inside of the arm. And yeah, that's what I learned from that patient. Ironically, he ended up having COVID, and I did not know that before I saw him. I'm totally fine. He had a mask on, and I didn't touch him. Like, besides getting the IV, I wasn't close enough to breathe in any air for it to be air like contamination. I'm totally fine. I've been tested. I'm okay. So just wanted to clarify that. But I thought it was funny. Michael came up to me and was like, "Yeah, he has COVID," and we didn't know that. And that's just the dangers of being a nurse, because sometimes you don't know what the patient has, and you'll be exposed to that. And that is also why it's important to get all your vaccines be updated. Yeah, that was officially BMH Day 1. Right, so now to talk about BMH Day 2 and what I had learned. That was a very busy day, and I saw a lot of people to get blood drawn and to start IVs, and I saw a lot of that. But I wanted to talk about 4 specific patients that I saw that I learned a lot from, I felt. I will refer to them as patient A, patient B, patient C, and patient D. So patient A was a very sick woman. She had an upper GI bleed, and which caused, when it's an upper GI bleed, the symptoms are you throw up light colored blood and then you poop out really dark colored blood. And that's how they knew it was in the upper gastrointestines, because she was vomiting light red blood. And she needed a unit of blood because she was losing a lot of blood quickly, and because of the upper GI bleed. So I got to see the blood bank in the hospital, which this may sound stupid, but I hadn't realized that there were blood banks. There are blood banks in the hospitals. I thought there is one building where you donate all your blood to, but then that building sends blood to every hospital surrounding it, and gives them blood, and they have their own mini blood bank, which is like just a little room where you have a refrigerator of blood, and it's and each patient, if needed, will have units of blood prepared for them. They're based on their types of blood, type A, B, or O, and positive or negative on those types. So she needed a unit of blood, and when getting a unit of blood, you need to, every time you get one, you have to clarify that it is for the right patient, and it's the right amount of blood, and it's going to the right person for the right reasons. So we had to clarify her age, date of birth, her name, and then we also had to get an order for her before we could even get the unit of blood, and then we had to clarify her name, age, and why she was getting it, and then we had to there's a code or a number, kind of like a serial number on the bloods, and we had to read that out to make sure that we were giving her the right blood, the right type of blood, because that could be detrimental to the patient if they receive the wrong type of blood. So each time we had to get one, every time you have to get a unit of blood, you have to go through that process. And so we got her unit of blood, and then she had to get sent to the PACU, which is it's on the upper floors, and it's basically where all of the surgeries are performed, and the emergency surgeries are performed in the PACU. And she had to get an endoscopy, which is where they take a camera down her throat and into her gastrointestines to see where that bleed is and what is going on in her body. And right before she went, we got her another unit of blood because she was still losing blood, and her heart rate wasn't good, so she needed and she was just pumping blood but not getting it through her body because it was bleeding in the upper GI bleed. I don't know what happened to her. The day was extremely busy, and a lot of patients I didn't find out what happened. So I will just be clarifying that. I hope she is okay, and I hope her endoscopy, they were able to target what was going on. And I feel bad that I never checked up on her, but there was so much going on every single day that it's very difficult to check on past patients if they're not like your specific nursing patients. If you're not a nurse with specific patients, it's very difficult to check on all of the patients that you've seen in the past. Especially when they get sent out of the ER. Once they're out of your hands, you don't know what happens unless they come back. For patient B, he was also very sick. He had a respiratory failure, and he had high levels of CO2 in his blood. And so they were debating whether or not to intubate him. I had thought they said incubate, but they said intubate, which is when they put a tube down your nose or your mouth into your trachea, and that will open up your trachea to your lungs, and which is the trachea is your airway or your windpipe. It opens the trachea officially and gives oxygen straight to the lungs, but this can be very dangerous because once you get intubated, you likely need to get on a ventilator, and it is very difficult for patients to get off of a ventilator. But what I heard from his CO2 levels were decreasing, and he was breathing, and he was taking in the oxygen from the mask that he was given, and he did not need to be intubated from what I know, and I hope that he is okay. For patient C, patient C needed an EKG. He had gone to a doctor, and the doctor, when getting the results back, said that he needed to go to the ER. He has had heart problems since 1996, and we have a file on him since 2020 that says that he still has a right bundle branch block, which those are found in the second segments of the heart, and it will be a little increase in the beat if there is a right bundle branch block. And I naively was like, why don't they just unblock it if he's been having this issue for so long? That you can't do that unless there is an underlying cause to the right bundle branch block. It is permanent, and he will have that block for the rest of his life. And that is his normal heart rate is with that bundle branch block, and he was okay. From what I know, he ended up being okay. And also, I wanted to say that also reasons why we take EKGs is to knock out a specific type of heart attack, which is the STEMI heart attack, which is in a specific segment of the heart, and it can be found on an EKG. And if it's not that heart attack, that type of heart attack, there's another, which is a non-STEMI, which is found you diagnose it through the blood test. And from what I know, he didn't have a heart attack. At least he didn't have a STEMI heart attack. I don't know if his blood test came back that he had a non-STEMI or not, but from what I know, he was okay. He was a really nice man, and I hope that he feels better soon. He was out of the ER by the time I left, so I hope he's okay. And then finally for patient D, she had type 1 diabetes. I don't know specifically why she was in the hospital, other than that she was low on insulin, and I know that she needed insulin, and the reason why she is low was because she only needed 2 units of insulin, but she hadn't been taking insulin at all. And this is because a lot of insurance companies don't fund insulin, and they don't, and a lot of diabetics need to decide whether or not they're going to eat or buy insulin. It has to be out of pocket if the insurance company doesn't cover it. So a lot of times they decide to eat over taking insulin. Not like overly eat, but get the right nutritions for the day. It's either they starve or they buy their insulin. That's how expensive it is out of pocket, and a lot of people can't afford it. And that really upset me. But I did learn that there are insulin pumps, or insulin pens, sorry, and they're a lot like EpiPens, but they have 300 units or 300 milliliters of insulin in the pen, and basically you take the cap off, you clean the pen, you put on the needle, and then you will scroll at the end of the pen. I'll show a picture right here. At the end of the pen, there's a scrolling unit, so you can scroll up to 2 units if the patient needs it, and then you will squeeze where the patient needs it, either in the stomach or on the fatty part of the arm right here. You'll squeeze that and then stick it in, listen for a click or a thunk. There will be a very obvious sound, and after you hear that, then you use your thumb and press down on the end of the pen and inject that insulin, and then take out the pen. And it's super easy. It's a lot easier than counting up insulin with a needle. It's very difficult to find out how much to do that, how much units the patient needs. It's a lot easier just to click the pen and pop. And so that was, the doctor ended up setting her up with some insulin, and I'm really happy. I hope that insulin covers her for a while, and I'm really thankful that the doctor was nice enough to do that, because likely the insurance will cover her will help with her hospital bills, which covers the insulin a little bit. So I'm really thankful that the doctor gave her that insulin, and she seemed like she was going to be okay. She was very nervous when she came in, but other than that, she seemed completely fine. And I'm really glad that she got out and she got her insulin. And that was BMH Day 2, so thank you for listening to that. All right, so for today, for BMH Day 3, I will talk about what I learned, and the Day 3's craziness came in waves. It was very slow at the beginning, and then got really crazy in the middle, and then slowed it back down again. I will be talking about 4 specific patients that I saw. I will refer to them based on their room number for the day, and this is not going to be able to identify any patient, because there were a lot of patients that went into into these rooms, and so you can't just be like, you can't identify them based on their room number, because there are so many patients that go in and out of those all of those rooms every single day. So just want to clarify that. So there's patient 1A, patient 2A, patient 3A, and then patient 4. So for patient 1A, he came in because he had symptoms of a stroke. He was slurring his words, and his right side of his body was, he wasn't able to move it, which is clear signs of a stroke. So he was a potential stroke victim, which when that happens, there's a very small amount of time to diagnose that and help that. So he was immediately cared for. He got a CT scan and immediately, and then he got on call with a telehealth provider in Dartmouth. He was a doctor in Dartmouth Hospital. And the doctor asked questions based on where the stroke could be. So there are 9 different lobes in the brain, and based on those lobes, if the stroke was in a specific part, it could affect the specific function of the body. So just as an example, the frontal lobe, if a stroke is there, then the patient will have memory problems and will have language problems. And so the doctor asked questions based on memory and mobility and comparing. So he asked the patient what year it was, what his name was, and what his wife's name was. And then he asked the patient to squeeze his hands one at a time, and then to lift his legs one at a time. And this is to compare the right and left side of the body, because the strokes can different lobes control different parts of the body. So they can target where that stroke was and what kind of stroke it was. So and as he was there, he was improving himself. So he ended up having a mild stroke, and it was self-resolving. So he was improving on his own, and he only needed to stay in for at most 24 hours. But however, just to monitor that stroke. But if he was having problems with walking again due to the stroke affecting his right leg, then he would have to stay for physical therapy, and that was the only reason why he would have to stay for more than a day. And yeah, he seemed like he was improving last time I saw him, and I was really happy for him. Obviously, not that he had a stroke, but that he was improving on his own, and likely wouldn't have lasting effects. There are a lot of stroke victims that will lose memories, and they won't be able to move their specific parts of their bodies for long times. And it's a very good sign if if that stroke is resolving on its own. And I'm really glad it was only a mild stroke, which again, not only like a stroke isn't a big deal, but that it wasn't worse. So then for patient 2A, I saw a procedure get done on him. He had a very swollen knee, and basically it was due to hemoglobized blood in his knee, and the doctor needed to extract that. And for that procedure, he needed an 18 gauge at 1.5 inches, which is a very big needle. And this is because the blood was very thick, and he needed a big needle to extract that blood. He numbed the patient first and made sure he had a sterile environment. So basically, he was given a kit that had that had anything that he needed in it, and we never touched the only person that touched the needle and the syringes were the doctor himself, after he put on the sterile gloves, which the gloves come in a little package, and when you open them, they are folded at the ends. So basically, when you put it on, you're only touching the part that will touch your skin, and then same for the other side. And so that is really that's a way to keep it sterile, is to not let anyone else touch it other than the gloves that are sterile and the doctor. And he's sterile because of those gloves. The procedure went well. He got most of the swelling went down due to extracting that hemoglobized blood, and then they took it to get it tested on and to see if there was any reasons for any problems with that blood, and that patient got sent off. And I did want to comment on the patient. There are very different ways that people react to pain. They can be very loud, or they can be very, very quiet. And for this patient, he was quite loud, and it was a good experience to not react to a patient being loud. You want to comfort them, obviously, but you don't want to laugh at their reactions to pain. This patient kept moaning, "Oh Jesus," the whole time. And obviously, that's his way to show that the pain is unbearable to him. A lot of the people thought he was exaggerating a little bit, because but maybe that was just his way to show pain, to show that he was in pain, and to vocalize that pain, was to constantly for an hour straight say, "Oh Jesus, oh God," over and over again. Not funny, not funny. I did not laugh at the patient. I'm not laughing at the patient, I'm laughing at the situation. But for patient 3A, I will move on to her. I never saw her. She was in the psych pod, which is I'm not allowed into, which are really suicidal and really violent patients. They get put in the psych pod, and basically that's where they room to keep away from other patients and from other doctors and nurses that aren't allowed to interact with them like me. And she got a code green called on her. This was a code green means a violent patient, and basically this was because she had charged at the nurses, and showed that she was violent. She never hit anyone. No one got hurt, but as soon as she started charging at the nurses, they closed the door and called a code green on her to get security and try to de-escalate the situation. She had believed that she was being held against her will there at the hospital. She didn't understand that her actions of being non-compliant and being very loud and aggressive, she didn't understand that those actions had consequences, which were to stay at the hospital longer and to monitor her longer. So she got very mad, and once the nurses sympathized with her and explained the situation and were very comforting to her, she willingly took her medicine and calmed down. And that just shows how great of a nurse. Her name was Julian. She was amazing. And Michael said that she was also amazing in this situation. I got to see on the cameras what was happening, and I could hear what was happening, and they explained it to me afterwards a little bit more. And lastly, for patient 4, she had a migraine, and she had been having a migraine for over a week, and it was not improving. The lights actually hurt her. She wasn't able to. She had sunglasses on, or she covered her eyes with a blanket, and basically, she needed to get a lumbar puncture, which was to extract spinal fluid, and basically they use a hollow needle, and they find a in between the columns of the spine, and they inject that needle and pull out the spinal fluid. And basically it's also called a spinal tap, because it taps into that spinal fluid, basically. She needed to be she needed to be numbed and then given that spinal tap. And basically I saw again that it needed to be completely sterile, and everything needed to be cleaned and monitored. And she was also a very loud patient. She expressed her pain by yelling and screaming, which is very common and also good experience for me to not react to, again, the yelling and the screaming, and be prepared for loud patients, because there'll be a lot of loud patients in my time as a nurse, hopefully, in my time as a nurse. And I just need to expect that and to be prepared for it. It ended up actually that the doctor had accidentally mislabeled the spinal fluid. Basically, there are 4 tubes that contain spinal fluid: tube 1, tube 2, and tube 3, and tube 4. And they are all already labeled, but he accidentally took tube 2 and put the first bit of spinal fluid in that, and then took tube 1 and put the second spinal fluid in that. And the reason why that is so important, and it was an accident, but it needed to be clarified, because basically they need to know the order of the spinal fluid extraction, because to see if there's any contamination. There could be in the first one or the last one, and you need to know the order of it to see if either the spinal fluid is contaminated or if that is actually what the test resulted in. And spinal fluid taps, the spinal taps, they they will identify any issues in the central nervous system, so any brain or heart injuries or diseases, not injuries, but diseases, and that's how they find that out, is through the spinal tap. So they were trying to find out if there was anything wrong with her brain, because she was having a migraine for so long. And we also talked about me and Michael. He told me about how when you're working in the ER or as a nurse, you need to make sure when you're arguing, if there's an issue and you end up arguing with someone, you need to attack what they're doing and not who they are as a person. That's a very good advice for life, but especially in the medical field, there will be a lot of different ways to perform procedures, and it's, again, as I said before, it's evolving and it's changing, and you need to ensure that everything is being correctly done, but you don't want to attack the person, because you don't want someone to hold a grudge against you. You want to have good work environments with people, because if people are holding grudges against each other, the energy is off and they can't work together very well. And especially in the ER, they need to be able to work together well. And that was really important. And I just wanted to explain that to you too, because I learned that. Okay, thank you. All right, so for the fourth and last day at BMH, I will be talking about what I learned then. And today, day 4 wasn't as crazy, but there were only 3 patients that really stuck out to me, and I wanted to explain what I learned from them. So I will be referring to them as PA, PB, and PC. So PA came in for a UTI infection and a bacterial infection in her kidneys. And she was an elderly woman, and I didn't really learn from that diagnosis, but instead about how to approach more elderly people, which is the field I want to go into. I want to go into geriatric nursing, so how to approach them, and also how to approach people with memory issues. So basically, first, she was an 86-year-old woman who had who wore a diaper due to the inability to control her bladder and her bowels. And I want to say and clarify that this is very normal. When you're 86 years old, you will not have control of your body anymore. You will barely be able to move, and you won't be able to control yourself when you have to go to the bathroom. It's even as in your 50s and your 60s, you start having issues with bowel, specifically with bladder control. And I don't want anyone to judge this woman because she was wearing a diaper. You never want to judge. You want to be understanding when in the medical field. And I'm sharing with this to you so you can understand and not so you can judge. So please, please don't judge her based on her actions and because she was wearing a diaper. I just want to explain what I learned. So just a little disclaimer before I get into it. That was it. So she had come to the ER the night before, and she had not changed her diaper at all. She had forgotten in the craziness of everything. She was sick and she wasn't able to change it. So we had to change it. And when changing a diaper, you need to be very reassuring and very comforting because they are very embarrassed. And, well, she didn't seem that embarrassed. She wasn't like, bragging about, being unable to control her, making us, change her diaper. But she was just laying there, and we kept being like, it's okay, this happens, and just that you need to remember to change your diaper if you can on your own. And she usually did. So it's likely because of the whole situation with her infection and the whole craziness of the day, she was unable to change it herself. But so we got the diaper off her, and then we cleaned her up, and then we would move her. And this is really a 2-person job. So you hold her to one side and pull out the dirty sheets from underneath her, and then move her to the other side and hold her there and get the rest of the sheets off. That's how you do that. It is very difficult to do by yourself if the person is unable to move, and she wasn't able to get up or move because of the pain and her situation as an elderly woman. So we got her the sheets off, and then we put more sheets on, again moving her as needed. And again, that's why it's important to have at least 2 people when changing someone if they are unable to move, because you need someone to hold her and then someone to apply the sheets. And then we put a new diaper on her, cleaned her up, and she was good. She was all good. But it was good experience because I really want to go into geriatric nursing. I really connect with older people and I love them. and I want to help them. And it's also a lot of it's needed. There's a lot of elderly people that need help, and there are not a lot of nurses to help them. And so, and there's a lot of there's also a lot of negligence in geriatric nursing, because nurses get burnt out and take out their aggression on elderly people, and that's not as monitored anymore, and it needs to be. I want to help that. I want to improve this system of for nursing homes and in hospitals with elderly people, because nurses get burnt out, and then they take out their aggression on the patient and just neglect them, and the patient can't do anything because they're too sick and they're too old to call out and get help. And there's not a lot of family for elderly people that if they don't have a good support group, there's no way to catch it. So I really want to help with that system. But that's not all that I learned from her. She also likely had some dementia, or Alzheimer's, which is a diagnosis of dementia, but basically some cognitive memory issues, because she saw me as her son, and because she's an 86-year-old woman, likely she was remembering a time when she was in the hospital before, and her son, when he was around my age, was there with her. But this time he was nowhere to be found, but she was calling out to me because she was in the memory from before, from the past, where she, this is just what I interpreted it as, and what happens a lot with memory patients is they get, they trigger a past memory and they live through that memory again, and that's why they believe you're someone else, because you look like someone else. And I guess I looked like her son, and I regret how I handled the situation, and I'm going to explain why. So basically, me and Martin went up to her. She had accidentally hit the call button. We made sure she was okay. She looked at me and she said, "Oh, I thought you were my son." And we were like, "Nope," which is first mistake. Don't correct them, but I'll go into that later. We said no, and then we left, and I never, she kept calling out to me. She still, even though we corrected her, which you're not supposed to do, she still called out to me because she still saw me as her son. And I didn't do anything because I was scared. I was afraid. I didn't want to worsen her condition. I didn't want to confuse her or upset her. And so I could see it going wrong in both ways, because I wasn't sure the right way to approach it. I could see that if I corrected her, that would confuse her and upset her, and which is what you're not supposed to do. But I thought that also if I went along with it, that that would also confuse her memory. But that is the way you're supposed to do it. You are supposed to go along with whatever they say. You don't have to overexert yourself. Be like, "Hi, Mom, how are you doing?" Just nod and be like, "Yes, I'm here to care for you. I want to help you." And just let them believe you're who they think that you are, because it will hurt more if you deny or you correct them. It will hurt their memory, and then they'll just forget that you had corrected them. So it's a losing battle when you're trying to correct them. So just go with it. And I know that now, and I'm going to correct my mistakes. I will make sure I will remember this regret, and I will ensure that it doesn't happen again. So, yeah. On to PB. I didn't see him a lot, but I did learn about him. I actually didn't see him at all, but he had overdosed on, he tried to overdose on aspirin. So we don't know exactly how much aspirin he had taken. He said he just took a handful, but that could be, it depends on what kind, if it's baby aspirin or if it's adult aspirin, because they're different milligrams. But to combat that, anyways, he had to drink activated charcoal, which would absorb the aspirin and cause him to vomit it up, until they were able to figure out how bad it was. I don't know what happened, if he's okay, but I do want to say that overdosing on aspirin, if you purposely do it, it's a very slow death. It's very painful. All your functions will just shut down. So don't try to kill yourself at all. Let me say that. Don't try to ever do that. But if you're thinking, oh, aspirin, if I just overdose on aspirin, it's going to be quick, it's going to be easy, I'm not going to feel it. You will. It'll be very painful and very slow. Your body will shut down, and it's not good. And you just have to monitor the patient that ends up overdosing. But yeah, I didn't know activated charcoal did that. So I learned that, and I thought that was really interesting. Obviously not him overdosing on aspirin. That wasn't interesting. But anyways, on to PC. I learned the most from him, or I saw the most from him. He had fallen and claimed he claimed that he didn't fall on anything, but there were like 4 gashes in his stomach. There was one like in the middle, and then 2 on the side and 1 on the back, and then he had broken his nose and had a cut inside his nose right here. So I got to see him get stitches, which was really interesting. I saw him get numbed and get stitches. He got about 14 in total. And then after that, I got to see him get an ultrasound, which I didn't know this, but ultrasounds are also used to to identify if there is any internal bleeding. They're not just for babies. That's why I was really confused. They're to identify internal bleeding, and he seemed okay. But it was very hard to see, apparently, for the doctors, because he was a larger man. It was very hard to decipher if he had internal bleeding or not. But there were 2. They clarified there was no internal bleeding. He was okay. He did have to get sent to Dartmouth because they needed to to help his they didn't have at BMH, they didn't have the correct way to fix his broken nose, so he had to be sent there. And I hope he's doing okay with his at least 14 stitches in his stomach. It did turn out that he remembered that he was holding a porcelain bowl and likely fell on that and cut open his stomach. So just be, if you're holding porcelain bowls, try not to fall, because you will hurt yourself on it. And also, I also got experience from him because I got to help the doctor a little bit, which was really cool. I got to get them chucks, which are the little green pads that absorb any bodily fluid and keep the space clean. So I got to get her some more chucks, and I also got to move the light from on his stomach and into his nose to get that final little stitch right there. And I also helped clean up afterwards. There was a little blood on the counter, so that I cleaned up, and picked up all the trash off the floor and put it, if it was bloody, put it in the biohazard. If it wasn't, put it in the regular trash bin. And then I took his clothes and sheets that had blood on them and put them in a yellow bin, which is for soiled clothing and anything like that. So I got that done. And I also helped a little bit around the hospital by, I had, on day 4, I had helped, there was a cleaned room, so I set up the bed. I got to fix up the bed with the sheets, and I did it correctly, and I was really happy about that. And then I also, a patient needed his lunch, and Martin was too busy, so I grabbed his lunch for him, gave it to him, and also got him a few extra things that he requested. And he said I was really nice, and that made me feel really good and really helpful. And I also just, I really enjoyed day 4, my last day, and I learned a lot in total. But thank you for listening. So to wrap up what I learned from BMH, I learned a lot from the nurses, and I learned that even if it's an ER, I really want to go into the nursing field. I want to learn more about the medical, whole facilities, and I want to help people that way with medical problems. I yearn to learn more, and this helped with my yearning. That sounds really weird, but I had been really nervous about the ER because I was scared that I would freeze up and I wouldn't like what I saw, and I'd applied to nursing schools, and I wouldn't be able to go and continue this pathway. But I want to do it, and I really am happy that I learned that from this, from what I learned at the ER, and the nurses were really great. And even though I know I'll get burnt out, there are ways to combat that. What I learned from Michael is that if you get burnt out, you can just switch to another field. Like if you're in the ER and you get burnt out as a nurse, you switch to children's like nursing. If you are in children's nursing and get burnt out on them, switch to geriatric or switch to home health care. There are lots of needed nursing fields. And as long as you have your registered nursing license, you can switch to any of them. So instead of just quitting, which a lot of nurses do when they get burnt out, they quit, which is understandable. But a way to combat that burntage is to just switch out of what you're working on now and get new insight, get more experience, see new things, and seeing that will help you with your like burning out. And so I know how to combat that. And also there will be people that I work with that I may not like, but I have to be professional and I have to just try to do my best, and I think I will be able to combat that as well. And I really enjoyed it, and I learned a lot from these nurses, and I wanted to thank them for that. And thank you for listening to what I learned at the BMH. Hello. So right now I'm going to talk about the what I learned from the nurses here at Putney. So there were some specific things that I wanted to go over with them, and some weren't able to be answered because they didn't have the ability, or and because it's just difficult to teach just one-on-one a little bit without having all the equipment. So I completely understand that, but what I did learn, I'm really excited to tell you about. So, first off, I learned about lymph nodes, and basically they are the they are all over the body, and they are the way that our body fights off any pathogens and any bacterial viruses, anything like that. Basically, if your lymph nodes are swollen, that means that they're doing their job and that your immune system is doing its job. It's how they combat their whatever gets in our bodies. And then we discussed how to take blood pressure manually. So basically, I had learned a little bit about it, but I didn't fully understand. And going over it one more time really helped because they explained it a little differently, and that helped me a lot. So first, to go over what systolic and diastolic blood pressure means. So systolic is the highest number on blood pressure readings. So basically there's one really big number and one kind of smaller number. That the big number, the top number, the numerator is the systolic rate, and then the denominator, which is the smaller number, is the diastolic rate. And basically the systolic rate is when the heart is pumping, and it's when it's at its highest pressure. That like action of pumping is what the systolic is measuring. And then the diastolic is when the heart is relaxing, coming out of that pressure. So systolic, diastolic, systolic, diastolic, and it's measuring those rates. And basically, you take manual blood pressure by getting a blood pressure cuff and a stethoscope. So you attach the cuff to the upper arm of the person, and it can be higher or just as long as it's in this area, it's good because it's going to cut off the blood flowing to the vein that you are the pulse that you are reading the blood pressure from. So basically, you attach that, make sure it's nice and tight. Don't be scared to put it on too tight, but make sure it is the correct size, because there will be a little index that will say where it should be. It should be in between. And if it's shorter, that if you're not able to go to that index, that means that the blood pressure is too small and you need a new one. The cuff is too small, you need a new one. If it goes over that index, or if you can't even like attach it, then you need a smaller that blood pressure cuff is too small and you need is too big and you need a smaller blood pressure cuff. And so you'll put the blood pressure cuff on the patient, and then you'll put the stethoscope into your ears and feel underneath the blood pressure cuff right here, right where the pulse will be. And basically you won't be able to hear it because it's not that loud, because there's no pressure coming at the that's cutting off the pulse. So it's very quiet right there. So once you start squeezing the bulb, once you start squeezing the bulb, then it will, the more pressure you put on the arm, then you'll start hearing the heartbeat. And basically you want to squeeze that bulb, you want it to have you want to tighten the air release valve to its tightest form, or like not tight enough that you're not letting any air out. But if you do it at its tightest, then you might not be able to unscrew it one-handed, so be wary of that. So basically, you make sure it's not leaking any air, and then you squeeze the bulb until you'll hear the heartbeat, and then you'll stop hearing the heartbeat. When you stop hearing the heartbeat, then you start releasing the air from the air release valve, and you loosen that. And you will keep hearing the heartbeat, and then you'll stop hearing it. At that, the number when you start hearing the heartbeat the first time, after it has been the pressure has been released, that is the systolic number. And if once you stop hearing the heartbeat after you've released all of the air, that is the diastolic number. It'll be very obvious which one's which. So basically you'll squeeze until you can't hear the heart rate anymore, and then you'll watch the gauge, and when you start hearing the heart rate again, that is the systolic number, and then you'll release more air, and when you stop hearing the heart rate, that is the diastolic number. And next that I learned is about medical history. So I was a little confused on not the importance of medical history, but how much it is needed. So basically, primary care, when you're in just for a doctor's visit, you might not be asked a whole lot of questions. You'll be asked very generalized questions about your safety, about how much you're smoking, sexual activity, all those a little invasive questions. Yeah, those are really important, because knowing all of that will help determine and pinpoint what is going on in your body, and if there is anything wrong with your body. It can help the doctors be able to find a diagnosis and be able to target a diagnosis that they need to. If they don't know, let's say your family has diabetes and it runs in your family, you're very likely to have, especially if it's diabetes too, with with the way you were raised, with diabetics in your family who have diabetes too, which is the diabetes that you develop later on based on your diet. Basically, if you're eating like whatever your family was eating that have diabetes too, then you're likely to also get it. It's very sad, but a lot of people don't realize that. They may think that just one vegetable a day is enough, but you really need a good amount. You need a vegetable at least every meal, and you need to make sure that you're not taking a lot of cholesterol. Like it doesn't have high levels of cholesterol, and high levels of sugar can really mess up your body. And like a normal amount is fine, but you don't need to be having hundreds of grams of sugar a day. That is too much. Diabetes is based on your control over insulin in your pancreas. And if you can't control the levels of it, then you develop diabetes type 2. And so I learned that a lot of patients may not realize how bad their lifestyle is until they're asked these questions. They may not realize that how important it is to answer these questions, and they may realize, oh, I'm doing something wrong with my life if the doctor is asking these questions. And also, the ER, let's just say the ER, they will ask more generalized questions on what specifically they're looking for. So like if patient comes in with a stomach pain, they will ask questions related to maybe getting a diagnosis on that stomach pain, about past medical history, things that could be related to that, while the primary care is more generalized and just finding out if anything is wrong with you or if you are in high risk of developing anything in your body. I also learned about pupils, and basically they are the instead of the window to your soul, they're the window to your brain. If your pupils are highly dilated and they're not reacting, there likely is brain damage. And it's very important to see those reactions. And if a patient comes in, you don't even have to do the whole light in front of the eyes. If a patient comes in and their pupils are dilated even in light, just natural light, like as you can see, my pupils are not dilated, they're at the normal size. If they were blown out, that means I likely have brain damage or a brain bleed somewhere. And then if you see that, then you just send them to get a CT scan and make sure and try to target what is causing those pupils to be blown. Or you can ask if that is a natural thing, because it could be a a symptom, or it could be a symptom of brain damage, or it could just be something natural that happens in their life and it's their norm now. The doctor needs to know that before sending for a CT scan. So that's also why medical history is important. And I also learned about injections. So basically, there are 4 types of injections. There's the intramuscular injection, there's the subcutaneous injection, there's the intravascular injection, and there's one more I can't remember. But the intramuscular injection is the one I learned, and it's when the medicine is injected straight into the patient's muscle, which allows the medicine to be absorbed into the bloodstream quicker. So that's why they use it a lot for vaccines and for regular medicines, because it's the quickest way to get the medicine into the bloodstream. And basically, what you'll do is you'll find the acromion. Not pressure. It's the bone right here. You'll feel for that. It's at the end of the shoulder blade, and you'll feel for that. And after you feel for that, you will make a V with your hands, with your fingers, and pull back that skin, and in the middle of that V is where you'll inject. And you want to inject straight into the arm and very quickly. You don't want to just go with the patient. That is not good. They're going to get freaked out and it's going to hurt even more. So just straight into the arm. Give them a warning if they ask for it or if they need it. Ask if they want a warning. Like, do you want me to go 3, 2, 1, or do you want me to just inject it? And they will answer whatever they feel best for them. If they want a little preparation, or if they just want to not know when it's happening. It's up to the patient. You need to ask though. But basically, injecting it straight into the arm will go straight into the muscle, and the needle will be longer for those intramuscular shots. And I thought that was really interesting. We didn't talk about much else, but they were just explaining to me that I do need to monitor my patients. So if I go in and just do a self little monitor, like see if I can see any symptoms visibly. And also, let's say if the blood pressure is really high, but the patient looks fine, that could be either a misreading on your part, or it could be just the patient's normal blood pressure. That does happen. A lot of people live their life with really high blood pressure, and they're completely fine. So you need to, before going crazy and being like, oh my God, it's 192 over 80. No, wait, 192 over 100. You need to just take a second, ask the patient for their medical history, if this is a normal blood pressure for them. And then if it's not, retake the blood pressure and then freak out if it's still the same. You gotta double check yourself first before freaking out. And just, I really enjoyed learning from them. They were really nice. I love Lauren. She was my sponsor, and Maria let me take her blood pressure, and I was really appreciative of that. And they were just very sweet and welcoming, because I mean, the nursing community is very small and short-handed, because nurses get very burnt out very quickly. And so any interest in the nursing community is a huge welcome. And I hope that this video interested you, or just in the medical field, or just that you learned something, because it's very important to learn about medicine and about your body, because you never know what's going to happen, and you want to be prepared. So thank you for listening to me, and goodbye.